Mhm. I did. You were looking at your phone.
Oh, cool. My bad.
Great news. I think I figured out my persona for this year's Tactical Village.
Introducing Rex Buckingham, British secret agent, ballistics expert, and ladies' man.
Yeah, because what woman doesn't love a guy who's super into make-believe?
This whole training simulation is make-believe. We shoot paint at fake bad guys. It's called acting. Tell me how I'm any different than George Clooney.
He has a sexy voice.
I have a sexy voice.
Champagne. Outrage. Hugs.
Mountain range?
I couldn't think of anything sexy to say.
What? Mountain range is the sexiest geological feature. Oh, wait, sorry. Deep sea trench.
I think I'm going to go talk to Rosa. You try to think of some sexier words.
Jesuit. Horticulture. Lamb.
What is going on with you two? Come on, Rosa, this again. You gotta fit the spark.
How many times do I have to say it? She's like a sister.
What about Leia?
Hey, Luke didn't know. No one knew.
Ni mtu ame-unmute.
All right.
Na ngoja ianze 7 minutes.
All right, fine.
Watu wako na ufala. Ana watch.
Gonna be in our
Kumbe watu wanaamkia movie 7.
Terry's couch.
Wait, Boyle set a date already?
Hey, you gave out save the dates yesterday. He didn't give you one?
I think he's been avoiding me.
Oh, I hate pizza.
He didn't invite me to his wedding and scared like a little bitch.
Well, maybe Vivian was uncomfortable with you coming. Look, Boyle was in love with you until a few weeks ago. Oh, don't be angry.
I'm not angry. I think it's funny.
Madiomba. Anasema dina munomba hivi mayo kasia.
Boring.
Thank you, yeah. Dismissed. Dismissed.
What you doing in here? Okay, and just your phone.
I may have been playing crazy cupcakes.
Okay, Captain, I think we're past the point of you being too proud to say the W.
Fine. I might have been playing crazy cupcakes.
It's so addictive, right? I play so much that when I close my eyes at night, I just see cupcakes now instead of my normal dizzying array of flashing lights.
Yes, well, I have a tremendous amount of self-control. I don't think I'll have any problem resisting this silly game. As a matter of fact, I've deleted the application.
Mimi.
Does this mean I've lost my progress? Well,
Okay, good morning, everyone. Shall we commence? Class rep? Class rep, can you hear me? Good morning. Can you hear me? My name is Dr. Onyuma. So today's discussion is going to be on cardiomyopathies. And to start us off with what the definition of cardiomyopathy is, these are diseases of the myocardium, and these are diseases which are generally associated with structural and functional abnormalities in the myocardium. So for an entity to qualify to be called a cardiomyopathy, usually there's absence of a definite disease process, systemic disease, that results in the cardiac structural and functional abnormality. So traditionally, cardiomyopathies have been classified into these 4 categories. The classification is based on the morphological appearance of the heart associated with the disease process. So the first one is the dilated phenotype or dilated cardiomyopathy. Second is the hypertrophic cardiomyopathy. Third is the restrictive cardiomyopathy. And the fourth is arithmogenic right ventricular cardiomyopathy. So in terms of frequency, the dilated phenotype or dilated cardiomyopathy tends to be the most common type. And the defect is often dilatation of the heart, particularly in the left ventricle. And this affects the systolic function, results in systolic dysfunction of the left ventricle. And I put this chart up here just to give us an idea of the etiological classification of the cardiomyopathies. So the primary types and the secondary types. So the primary types is the ones which we are not able to find a systemic disease that explains the cardiomyopathy. So in the primary types, there's genetic causes, there's mixed causes, and there's some acquired causes. The secondary cardiomyopathies, etiology would vary depending on several disease processes that can result in cardiomyopathy. So in a nutshell, this table puts us in context as to what are the causes and what are the types of cardiomyopathy that we have. So remember the definition and the phenotype of cardiomyopathy is based on the functional defects that result from the disease. So in the dilated phenotype, you tend to have impaired contractility of the heart, resulting in systolic dysfunction. In the hypertrophic type, we tend to have impaired compliance, okay, resulting in lack of dilatation during diastole and resulting in diastolic dysfunction. And in the restrictive type, again, you get impaired compliance, also resulting in diastolic dysfunction. So quickly, what is the dilated type or dilated phenotype cardiomyopathy? And results basically in from dilatation of predominantly the left ventricle. Sometimes it affects both the left and the right ventricle. And it can be associated with recognized cardiovascular disease. However, to qualify as a dilated cardiomyopathy, the diagnosis or the myocardial dysfunction cannot be exclusively explained by systemic disease. So, for example, patients who have hypertension or patients who have valvular heart disease or patients who have ischemic heart disease can have dilatation of the left ventricle. So in the absence of any structural or any systemic disease that can explain this dilated cardiomyopathy, then that is how you would qualify it as a dilated cardiomyopathy. It's relatively common, more in adults, but can also occur in children. In many cases, the disease can be inherited. So we have a familial type of dilated cardiomyopathy. In the familial type, there's genetic role, and this can result in development of both primary and secondary dilated cardiomyopathies. And the familial type, often there's a family history and there's an association with close relatives of patients who present with this dilated cardiomyopathy. In terms of penetrance, there are several genetic associations which have been associated with dilated cardiomyopathy. However, the genes which are associated with this disease are quite diverse. So the inheritance pattern is not really clear, but there's a diverse pool of genes which can be associated with dilated cardiomyopathy. The heterogeneity as a result of this diverse pool of genes is demonstrated, and the predominant mode is thought to be autosomal dominant. However, there is also X-linked autosomal recessive inheritance and mitochondrial inheritance, less frequent than the autosomal dominant pattern of inheritance. So family history becomes important. Family history of other diseases such as muscular diseases like muscular dystrophy, features associated with mitochondrial disease, especially if you're suspecting mitochondrial pattern of inheritance. And if the patient has signs and symptoms of other inherited metabolic diseases. So in terms of how these patients would present, the basic defect is that there's dilatation, okay, of the ventricle. And as a result, there's also dilatation of the valvular orifices, which occur secondary to dilatation of the cardiac chambers. The coronary circulation tends to be normal, And because of this dilatation and defect in systolic function, sometimes the blood flow is impaired, and as a result, you may find thrombi in the ventricles, or you may find thrombi in the atrial appendages. So this is an example of a cardiomyopathy with a dilated phenotype. So this is a section looking at the left ventricle. Obviously, as you can see, the heart looks enlarged, the ventricle looks enlarged. Okay, the wall looks a bit thinner than you'd expect, and also on top of so this is the valvular outlet. So you can see the valvular outlet also looks dilated and enlarged. Okay, so this is the morphological appearance of a dilated phenotype cardiomyopathy. So in terms of the appearance on microscopy, there tends to be fibrosis in the interstitium of the myocardium. Sometimes, or rarely, you may see myocardial necrosis in the subendocardium. Okay, so this is an example, if you remember from your histology. Okay, these are sections from the myocardium. Okay, so what is obvious here, you can see there's a lot of space in between the myocytes, isn't it? So this space in between the myocytes, so the fibers, the relatively eosinophilic or reddish, pinkish fibers, those are myocytes, and this bluish material in between is fibrosis. Okay, so you do not expect this fibrosis in a normal heart. Okay, so in a dilated cardiomyopathy, this is what happens. There is fibrosis. Okay, so how do these patients, how would they present? They present with features of congestive heart failure. Okay, and they may also present with thromboembolic phenomena. So we mentioned that you can have thrombi developing in the ventricle or in the chambers or even in the atrial appendage. So as a result, these patients are at danger of thromboembolism. Okay, so the clinical course can be prolonged, progression can be slow. Patients present with systemic symptoms like cachexia, wasting. They may have peripheral edema, typical in late stage heart failure. Sudden death can occur because you've seen the way there's fibrosis in the heart. The patients are at danger of ventricular fibrillation, and this can be fatal. Okay, so in terms of dilated cardiomyopathy, it's also important to remember there are certain cardiomyopathies which have a dilated phenotype. Okay, so there are certain cardiomyopathies where the disease process results in a dilated phenotype. So an example is the peripartum or postpartum cardiomyopathy. Okay, it's rare but is potentially life-threatening. Results in disease from previously healthy women occurring during the last month of pregnancy and can occur up to 5 to 6 months after delivery. Okay, the etiology tends to be uncertain. There may be a role for prolactin, especially cleavage of prolactin. Remember the hypothalamic pituitary axis is important in production of prolactin. Okay, so peripartum or postpartum oxidative stress results in abnormal cleavage of prolactin. Unbalanced oxidative stress would trigger cleavage of the nursing hormone prolactin and results in a potent anti-angiogenic, pro-apoptotic, and pro-inflammatory type of molecule. So in the postpartum cardiomyopathy, this is a schematic diagram just to try and explain to you what would typically happen. So Oxidative stress, okay, results in abnormal cleavage of prolactin, okay. This abnormal cleavage of prolactin results in a production of a 16 kilodalton abnormal molecule of prolactin, which affects the microcirculation, okay, resulting in recruitment of inflammatory cells and results in a pro-apoptotic anti-angiogenic type of prolactin, which affects the heart, okay. So as a result, you would result in patients would present with the dilated phenotype cardiomyopathy, especially in patients. The other important thing to remember is these are patients who are previously normal, not known to have heart disease, and then in the postpartum period, they go ahead and develop a dilated cardiomyopathy. So a classic diagnostic criteria of postpartum cardiomyopathy, developing heart failure in the last month of pregnancy or within the first 5 to 6 months postpartum, in the absence of any other cause of heart failure, in the absence of any recognizable heart disease prior to the last month of pregnancy. Okay, so the other type of cardiomyopathy with a dilated phenotype is stress-induced, or what is called Takotsubo cardiomyopathy. Okay, it was described by a Japanese cardiologist in 1991, and usually this dilated form or dilated phenotype cardiomyopathy is associated with intense emotional or physical stress, typically resulting in contractile dysfunction of the left ventricle, and ECG abnormalities can occur like ST elevation, mimicking a myocardial infarction. The important thing about this stress-induced cardiomyopathy is that it is transient. It is transient and reversible. So patients, in fact, the diagnostic criteria is after this cardiomyopathy, patients improve and come back to normal cardiac function. Okay. In the typical case, the left apex or the left ventricular apex is dyskinetic and it becomes expanded, and the shape of the left ventricle becomes dilated. Okay, and the name Takotsubo comes from a Japanese octopus trap, which has the shape almost like a pot. Okay, I'll show you that. I'll show you what I mean by that shortly. Typically, this condition is associated with elevated circulating stress hormones like the catecholamines. Okay, so the catecholamines are thought to play a central role in the pathophysiology of this dilated form of cardiomyopathy. So I'll put up a diagram. So on the top left of the screen is what is a Japanese octopus trap. Okay, on the bottom left, A is dilated cardiomyopathy and B is the normal shape of the heart. Okay, so you can see in A, the left ventricle is relatively dilated compared to this one. To B, the wall appears thinned, and if you believe me, it almost looks like this octopus trap in shape. So this is a dilated form of cardiomyopathy, okay, or Takotsubo cardiomyopathy. So what really happens with this type of cardiomyopathy? So there's emotional and physical stress, okay, which results in activation of the medullary autonomic center, which then triggers excessive sympathetic outflow. Okay, so when there's excessive sympathetic outflow, there's release of catecholamines like norepinephrine and epinephrine. Okay, so as a result, you will get exaggerated vasoconstriction, increased sympathetic neurohormonal activity, okay, myocardial stunning, and as a result, you get dilated cardiomyopathy. So, like I mentioned, this is a temporary phenomenon, and the cardiac function resolves, okay, days to weeks after the initial presentation, resulting in normal cardiac function. The other causes of cardiomyopathy are drug-induced cardiomyopathies. Several drugs can cause chronic cardiac dysfunction. Okay. So many drugs administered chronically for a long period of time can be cardiotoxic. Some of them, like patients who are on cancer treatment. Okay. So patients who are on treatment for cancer, some of them can develop a long-term cardiomyopathy. Drugs like anthracyclines, okay. Injury in the acute form can result in transient arrhythmias, inflammation with pericarditis and myocarditis, and then in the long term, chronic cardiotoxicity resulting in cardiomyopathy. Okay. This can occur even years after the treatment has been completed. Other toxins such as alcohol, okay, alcohol can result in cardiomyopathy, and then the cardiomyopathy associated with alcohol depends on, number one, the duration of consumption of alcohol and the dose of consumption of alcohol. A clinical cause of alcohol-related cardiomyopathy and prognosis is better when the individual abstains from alcohol, and recovery can be better than in patients who have idiopathic dilated form cardiomyopathy. And then the association with alcohol is thought to develop as a result of oxidative stress. Okay, so oxidative stress either by direct stimulation or generation of free radicals, or by activation of other hormones such as angiotensin. Okay, so the clinical cause and prognosis in alcoholic cardiomyopathy, just like I mentioned again, I think this is a repeat slide, is better compared to those with idiopathic dilated cardiomyopathy. So what would generally happen in the metabolism of alcohol? There's induction of reactive oxygen species. Again, there's also the effects of alcohol on the antioxidant, on the native antioxidant proteins and antioxidant enzymes. Okay, and then also alcohol is thought to activate a neurohormonal axis, so hormones such as the angiotensin and norepinephrine. We've already shown you how this would affect the microcirculation and affect the cardiac contractility, resulting in a dilated cardiomyopathy. Okay, so the other form of cardiomyopathy is the arithmogenic cardiomyopathy. Okay, so it's characterized by fibrosis and fat infiltration of the right ventricle, resulting in ventricular tachycardia and ventricular fibrillation. The left ventricle may also be affected in up to 3/4 of patients with the arithmogenic cardiomyopathy. There's some patients may die suddenly, especially a number of patients who are athletes who die at a young age have been found to have arithmogenic form of cardiomyopathy. In terms of genetic associations, about 30 to 50% are thought to be autosomal dominant in inheritance, and the genes associated are those which encode for desmosomal proteins. Okay, you remember the function of the desmosomes in the myocardium, in between the cells. Okay, presentation may vary, may range from mild symptoms like palpitations to syncope, and in the severe form, some may present with sudden cardiac death. The electrical instability of the heart manifests in terms of some patients get ventricular ectopics, abnormal beats in the ventricle on the ECG, and some patients can develop a ventricular tachycardia. Okay, so heart failure can occur, and it can be biventricular. And it can also be only the right ventricle. And in prolonged disease, long-term disease, patients who are at risk of sudden cardiac death are usually treated with implants. Okay, so implants, if the diagnosis is made early enough, these patients are candidates for implants to avoid the abnormal rhythm, abnormal heart rhythm. So this is an example of arithmogenic cardiomyopathy. So what strikes you most in the top left gross photo? Okay, you see yellow infiltration by fat. Okay, so the ventricle number one, it is dilated. It looks dilated. But then the most important thing here is there's infiltration by this yellowish fat. Okay, and when you look under the microscope, you remember, okay, these pink are the myocytes. Okay, and then you can see there are adipocytes. So these are fat cells. Okay, so there's infiltration of the ventricular wall by fat. Okay, so there are findings in terms of clinical diagnosis. It's very difficult to come up with a diagnosis on clinical testing because the findings can be very non-specific. The presentation would depend on a lot of things, whether how the fatty tissue has infiltrated the myocardium. Okay, so presentation would vary ostensibly depending on that. So there's no specific finding, for example, on an ECG or an echocardiogram that will tell us that this is a arithmogenic cardiomyopathy. Okay, so moving on quickly, the other form of cardiomyopathy is hypertrophic type. Okay, the hypertrophic cardiomyopathy is heterogeneous, autosomal dominant, usually results from mutations of genes encoding the cardiac, sarcomere, and myofilament proteins. So there are at least 10 different genes which encode for the sarcomeric proteins. And if you remember your anatomy or your histology from of the myocardium, the mutations occur usually in the beta myosin heavy chain gene. Okay, myosin binding protein C and troponin T. So these three the genes which encode for these three proteins are seen in 70 to 80% of cases of the hypertrophic cardiomyopathy. So just as a reminder, okay, this is a cardiac sarcomere. Okay, so the troponin complex, the myosin binding protein C, and beta myosin heavy chain. So the defects usually occur in the genes which encode for this protein. Okay, So mutations in the sarcomere can be found in 60 to 70% of adult and pediatric cases with a family history of hypertrophic cardiomyopathy. So this is a schematic representation just to put you into context, okay, as to what would definitely happen. So there's influx of calcium, okay, there's increased cytosolic free calcium, and then when you have increased cytosolic free calcium, you get left sarcomeric in the context of mutations, the mutations we've spoken about. There's increased sensitivity, okay? There's increased sensitivity to cytosolic calcium. So when there's influx of calcium, in addition to increased sensitivity to cytosolic calcium, you will get left ventricular hypertrophy, resulting in left ventricular failure. But our take-home message is the causative or the lesions, or what causes is the mutations in the myosin heavy chain gene, troponin C and myosin binding protein C genes. The phenotypic
Dr.
presentation, yes, yeah.
I'm sorry to interrupt you.
Yes.
Is it possible you can kindly ask that guy who is hammering in the background to maybe stop for a while till the class is over?
Okay, so give me a minute, please.
Okay.
Okay, guys, sorry about that. We can proceed.
Thank you. Thank you, Doc.
So the phenotypic presentation may be variable, and the usual presentation is that these patients have a long time before they present. So usually in the post-adolescent age is when this disease is detected. And usually in the hypertrophic type of cardiomyopathy, there's asymmetrical hypertrophy, okay? So if you look at the left ventricle in relation to the right ventricle, the hypertrophy is asymmetrical, okay? You can have right ventricular involvement in a small proportion of cases. Usually when it occurs, it affects the middle to the apical portion of the right ventricle. The changes which we see in the hypertrophic cardiomyopathy are characterized by cardiomyocyte hypertrophy, disarray of the myocytes. You get bizarre enlarged nuclei. There can be hyperchromasia and pleomorphism. And in the interstitium, there's increased interstitial collagen. So there's collagen deposition in the interstitium. So this is an example of a case with hypertrophic cardiomyopathy. And what strikes you immediately is the thickness, okay? The thickness of the right ventricle. So typically, you would expect the ventricle to be about 1.2 to 1.5 centimeters wide. So it tends to, this is much larger in hypertrophic cardiomyopathy. And if you look at the microscopic image here, the nuclei look bizarre, okay? There's disarray in that the myocytes don't seem to be organized. And then you see bluish material in between. So this bluish material tends to be collagen. And in the photo on the bottom right, you see the size and the shape of the left ventricle in relation to the right ventricle, okay? So you see it looks quite different, okay? So the other form of cardiomyopathy is the restrictive cardiomyopathy, usually characterized by impaired filling of the ventricle. And just like the name says, there's restricted filling of the ventricle. And if you may just extrapolate, this will result in diastolic failure, okay? Because you don't get enough dilatation during the diastolic phase. So the restrictive phenotype, there's defect in myocardial relaxation with interstitial fibrosis. You can get calcifications, and this results in restricted dilatation of the ventricle. As a result of this restricted filling, you can get passive venous congestion. Reflexly, the cardiac output will be increased, but is inefficient because of the shortened filling time. There are certain conditions which result in restrictive cardiomyopathy, okay? The most important thing is that they manifest with a clinical heart failure syndrome, and this can be indistinguishable from failure from that which is caused by systolic dysfunction. So in the restrictive type of cardiomyopathy, they can be primary or secondary, okay? So the primary causes, examples are endomyocardial fibrosis, low-flow endomyocarditis, and endocardial fibroelastosis. So we'll briefly describe what these are. And the secondary causes are basically diseases which result in infiltration of the myocardium, okay? So diseases like amyloidosis, sarcoidosis, radiation carditis, storage diseases, okay? So like iron disorders like hemochromatosis, the glycogen storage diseases, Fabry's disease. So in the secondary forms, there's infiltration of the myocardium by disease processes. So what would the primary cause? An example is tropical endomyocardial fibrosis, usually seen, not so common, but was previously seen in young adults, in people who are of lower socioeconomic status, usually peaking at 10 years of age and 30 years of age. The important finding in this is often there's fibrosis, okay? There's this deposition of fibrous tissue in the endomyocardium, and as a result of fibrosis, there's restricted dilatation of the ventricle. There are various theories or thoughts thought to explain the pathogenesis of this form of cardiomyopathy. Associated with inflammation and immunomodulation, okay? So diseases like infections, genetics, nutrition are all thought to trigger inflammation and immunomodulation, resulting in an eosinophilic mast cell fibrosis crosstalk. As a result, you get fibrosis, endomyocardial fibrosis. So there's also stimulation of fibroblasts to produce, or rather stimulation of fibroblast deposition by growth factors such as TGF-beta, and these are thought to result in the presentation. In terms of what is thought to causes, probably molecular mimicry, okay, as a result of crosstalk. I spoke about infectious agents and also spoke about genetics also plays a role in that. Molecular mimicry may result in autoimmunity, resulting in autoantibodies against the cardiac myofibers. So in a nutshell, this is a schematic diagram just trying to show certain associations. Again, infections resulting in inflammation, resulting in molecular mimicry, autoimmunity, resulting in fibrosis. So in terms of etiology, that is what is thought to cause or result in that, although we don't have consensus as to what exactly would cause this fibrosis. The important thing is that during examination of the heart in patients with this phenotype, the ventricles look small, and on histology, there is thickening of the endocardium, and there is endomyocardial fibrosis. I mentioned again, there's activation of cardiac fibroblasts, which lead to enhanced collagen synthesis. So you get deposition of collagen, okay? So this is an example of a case. So what strikes you obviously is the heart looks enlarged, the ventricular wall looks thickened, okay? But in this case, even on the gross examination, you see a lot of these white patches, okay? These white patches, this is fibrotic tissue, okay? And when you look at it under the microscope, this is a special stain which stains for collagen. So the myocytes stain this reddish, okay? Collagen would stain green. So you can imagine the myocytes have been pushed aside, and all this dense green is collagen, okay? So this is the fibrosis which results from the disease. The other form of primary form is low-flow endocarditis, is a restrictive form of cardiomyopathy which affects the endocardium and occurs as a result of proliferation of eosinophils. Eosinophils are important, and there are certain conditions which result in increased eosinophil or in eosinophilia. So diseases like the hypereosinophilic syndrome, eosinophilic leukemia, there are certain cancers and certain lymphomas. You can also get eosinophilia as a result of drug reactions or parasitic infestation. So the eosinophilic penetration of the cardiac myocytes leads to a fibrotic thickening of portions of the heart, presenting similar to what you see in endomyocardial fibrosis. Okay, so before we proceed, if anyone has a question, you can type the question in the chat, then we'll look at them after we finish, okay? So the other forms of restrictive cardiomyopathies, as we had mentioned, are basically diseases which result in infiltration, okay? These are infiltrative diseases, infiltration of the heart, okay? So we have diseases such as amyloidosis. So primary amyloid disease, as you may already know, can be caused by overproduction of light chain immunoglobulins. And often you see amyloidosis usually associated with diseases which affect plasma cells. You know, plasma cells, when they're terminally differentiated, they produce immunoglobulins. So diseases such as multiple myeloma, okay? Secondary amyloid heart disease can also be associated with chronic inflammatory conditions, okay? So diseases such as rheumatoid arthritis, diseases such as TB, diseases such as familial Mediterranean fever. The presence of near normal left ventricular dimensions, particularly you may get uniform thickening, okay? Because remember, this is a systemic disease that results in infiltration of the heart. So you tend to get uniform infiltration, uniform thickening of the heart. So this can be a distinguishing feature with other forms of cardiomyopathy, like the hypertrophic type, okay? So the other infiltrative disease is hemochromatosis, or you may already have heard of bronze diabetes, results from iron overload. Yeah? And as a result of systemic iron overload, you get deposition of iron in the sarcoplasmic reticulum with many organs, including the heart. The thing about excessive cellular iron is it results to cellular death and fibrosis. And as a result of fibrosis, you get a restrictive phenotype. Usually, if patients with iron overload are diagnosed early, then therapeutic phlebotomy can be helpful. And in patients who have a family history of hemochromatosis, family screening is often advised to avoid the end result of hemochromatosis. The other infiltrative form of disease is sarcoidosis, which is a systemic disease resulting from formation of granulomas, and these granulomas can infiltrate the myocardium, okay? It is associated with a restrictive form of cardiomyopathy in about 5% of patients, but again, it can also present as a dilated form of cardiomyopathy. The important thing about sarcoidosis is it is what we call a disease where you have to do a diagnosis of exclusion, okay? So there are several things which can cause granulomas, okay? From infections are the most common to infiltrative diseases. So in patients who have granulomas, like in the heart or any other organ, we have to make sure that it's not caused by any other infection. So an extensive group of tests has to be done to rule out other causes of infections. So in addition to that, the patient has to fit the clinical criteria for sarcoidosis for us to make that diagnosis. So there are other organs which can be affected, not only the heart. So it can affect the lymph nodes, it can affect the skin and organs such as the spleen. In the form of cardiac sarcoidosis, it can be associated with ventricular tachycardia and can present with heart block, which can result in fainting. So I think I'll stop there, and I've seen there's a few questions in the chat, so we'll just go through the questions quickly, okay? So the first question, Aisha is asking that, hello, exactly which cardiomyopathy falls under cardiomyopathy with a dilated phenotype? That's a good question, Aisha. So when I commenced, we spoke about dilated cardiomyopathy, okay? And then we went ahead and spoke about cardiomyopathy with a dilated phenotype. So this is what the difference is. In the dilated cardiomyopathy, remember, we do not know exactly what is causing it. So there's no systemic disease which can be used to explain that cardiomyopathy. But then cardiomyopathy with a dilated phenotype, an example I gave is the postpartum cardiomyopathy, okay? So if you have a postpartum cardiomyopathy, the phenotype, the appearance of the heart is dilated, but it can be explained by the stress induced during the peripartum and postpartum period. So there was a trigger in this case, which resulted in the cardiomyopathy. Okay, I hope that answers your question. Okay, so the second question, what is the difference between the restrictive, this is from Bashir, what is the difference between the restrictive and hypertrophic cardiomyopathy in terms of ventricular wall size and size of the ventricle? So important thing to know is what is restrictive cardiomyopathy and what is hypertrophic cardiomyopathy. And that is where your physiology of the function of the heart would come in, okay? So restrictive means there is failure, okay, of diastolic, or rather this diastolic failure, isn't it? Huh? So restrictive means that the wall has become rigid because of fibrosis. And so when the heart is filling, it cannot dilate completely, okay? So in the hypertrophic form, the wall is thickened, but it is not restricted, okay? It can dilate, but is not restricted. So in terms of, if you have like the example that you have said, so just reading this comment again, the size of the ventricle in the restrictive form will depend on what is causing the restrictive cardiomyopathy, okay? So for example, if you have infiltration by amyloid, okay, the size can be quite large, okay, can be comparable to the hypertrophic type of cardiomyopathy. So the size can be similar to the hypertrophic type, but then the restrictive type, it depends on what is causing it, because something is infiltrating the heart, okay? So either there's a deposition of collagen because of fibrosis, there's infiltration of the heart, or something is infiltrating it and making it thicken, okay? I hope that answers your question. Then Mohammed is asking, what is the difference between hypertrophic cardiomyopathy and cardiac hypertrophy due to hypertension? Again, Mohammed, if you listened at the beginning of the lecture, for us to classify hypertrophy, or rather, for us to classify a disease as a cardiomyopathy, we do not find a systemic cause, okay, which can explain the hypertrophy, okay? So if you have a patient who has hypertension and then they get cardiac hypertrophy, that is not a cardiomyopathy, understood? But in patients who have hypertrophic cardiomyopathy, we cannot explain this hypertrophy because they don't have hypertension, they don't have a systemic disease which can explain this cardiomyopathy. So in the absence of any other systemic explanation, we term this cardiomyopathy, okay? So, but cardiac hypertrophy due to hypertension, you can already explain, okay? You can already explain that this hypertrophy is caused by hypertension, okay? So there's another question. This is Aisha, this is a follow-up question, I guess, from Aisha. So Aisha, let me just look back at your question. Yeah, so Aisha, yes. So Aisha, you are asking, so stress-induced is not an example. Yes, it is an example. So I talked about stress-induced or Takotsubo cardiomyopathy. it is a cardiomyopathy with a dilated phenotype. So the reason it is a cardiomyopathy with the dilated phenotype is we know what triggers it. Okay, so in the stress-induced or Takotsubo cardiomyopathy, we know that there's a stress emotional, there's a trigger, and we know that this trigger results in elevated catecholamines, and we can explain that this is what caused the cardiomyopathy. So that is why we call it a cardiomyopathy with dilated phenotype. I hope that helps you, Aisha. Okay. So Lydia, the next question is by Lydia. What will be the gross morphology of the heart in hemochromatosis? So Lydia, this is basically an infiltrative disease. Okay. So remember, in hemochromatosis, because of the excess iron overload, sorry, I didn't have a picture of that in this presentation. You know, iron, if there's excess iron overload in the circulation, it will deposit in the organs. Okay, so when it deposits in the organs, just like in any organ, okay, remember, the iron will come generally from the circulation, and then just like when you have iron depositing in the organs, the gross morphology will be that of infiltrative. It will induce fibrosis. Okay, so you'll see fibrosis, and then grossly, because of the iron, you'll see a brownish, very dark brownish discoloration of the heart. But then, because iron tends to be quite fibrogenic, okay, fibrogenic means it induces a lot of fibrosis, then you would see the wall becoming fibrotic, and that's what causes the restrictive form of cardiomyopathy. Okay, so Lydia, I hope that answers your question. Next is Bramwell. Bramwell is asking, could you please explain on the diagnosis of restrictive cardiomyopathy? Okay, thanks, Bramwell. Oh, Bramwell, the diagnosis of a restrictive cardiomyopathy is difficult because, just like I said, it would depend on the cause of the restrictive cardiomyopathy. So is the cardiomyopathy caused, is it being caused by amyloidosis? Is it being caused by hemochromatosis? Is it being caused by sarcoidosis? So all these things have to be taken into consideration. Remember, the restrictive cardiomyopathy is a functional defect. So the thing which you as a doctor will pick up is that there is a diastolic failure. Okay, there's failure in filling of the ventricle during diastole, but you may not be able to pinpoint what is causing this failure until you do further investigations to find out, does this patient have iron overload? Does this patient have amyloidosis? Does this patient have sarcoidosis? So you will do tests. So there are tests which can check the function of the heart, like the ECG. There are tests like echocardiogram, which can be used to evaluate the heart. Okay, but then they will only tell you that there's a failure in filling of the heart during diastole. But in as much as what is causing the phenotype, you will have to still find out what is it an infiltrative disease resulting in the restrictive phenotype? Is it amyloidosis? Is it sarcoidosis? Is it hemochromatosis? So that is what that is how you would approach it, Pramod. Thanks. Okay, so the next. Okay, Mohammed is asking in terms of structural abnormalities. I'm guessing, Mohammed, this is in relation to the let me go back to Mohammed's question, initial question. Difference between hypertrophic cardiomyopathy and cardiac hypertrophy due to hypertension. Yeah, so Mohammed, in terms of structural abnormalities and differences, so in hypertrophic cardiomyopathy, like I showed you, the hypertrophy is not the hypertrophy that you would see in for example in hypertension, okay? Because remember, I think I had put up an image of hypertrophic cardiomyopathy. There's thickening, yes, of the ventricle, and also in hypertension, the ventricle will be thickened. But in cardiomyopathy, there's disarray of the myofibrils, okay? In such that they lose function, number one. So the structural disarray, and then there's fibrosis, okay? So that is a major structural difference. In hypertrophy due to hypertension, systemic hypertension, for example, remember, the myocytes are thickened, they increase in size, the myocardium is thickened, but the function is retained, and you don't get structural disarray, and you don't get fibrosis, okay? I hope that is clear, Mohammed. And then your follow-up on that is explain the complications of the liver in dilated cardiomyopathy. Okay, so in the liver, when you have a dilated phenotype cardiomyopathy, you get what is called a passive venous congestion, okay? So what happens is in a passive venous congestion, okay? Remember the way your circulation goes, okay? Eventually, you get passive venous congestion affecting the right ventricle, okay? The atrium, and then you get pressure all the way back into the portal circulation, okay? Now, if you remember the structure of the liver and the circulation of the liver, okay? When you have a passive venous congestion and there's backflow to the liver, you'll get, depending on, you remember the way I wish I had a diagram of that, but the way the liver is arranged, so you have a central vein, you have the portal circulation, okay? So you'll get congestion, okay, which is resulting from the backflow from the heart through the inferior vena cava, okay? So you'll get areas of congestion with intervening areas of lack of congestion. So the typical phenotype is what we see in what is called a nutmeg liver. I don't know if any of you has heard of what we call a nutmeg liver in passive venous congestion. So because of the backflow, there is passive pooling of blood in the liver, resulting in that sort of appearance. Okay. So the next question is from Niha. Niha asks, for secondary restrictive cardiomyopathy, aren't the infiltrative conditions a systemic explanation? So why are they still considered cardiomyopathies, but a bit confused of what actually being considered cardiomyopathy? Remember, Niha, I agree, if it can be confusing, but remember one of the things that we started off saying is that in the primary causes of cardiomyopathy, okay, we cannot explain what is causing it, okay? But again, the secondary causes, we have, for example, I'm guessing you're interested in the secondary restrictive cardiomyopathies. So we have infiltrative diseases, for example, like amyloidosis, hemochromatosis, sarcoidosis, and you may look at it as a misnomer, quote unquote, okay? Because in the strict definition of a cardiomyopathy, we do not know what is causing it, okay? But in terms of why these are secondary, that is why we class them as secondary, because we know it is associated with this, okay, with this infiltrative disease, okay. But then in the strict definition, cardiomyopathy are the primary forms of cardiomyopathy. So if you look at it in terms of, if you just mention cardiomyopathy per se, one would imagine you're talking about the primary forms of cardiomyopathy, okay? But we have to discuss all these other secondary forms because the presentation is similar, okay? So if you're investigating a patient with a restrictive form of cardiomyopathy, you will go there trying to find out if this is a primary or secondary, okay? Then, but when you're approaching this patient, you will call it a cardiomyopathy. Eventually, when you find the cause, then you say, okay, this is a secondary cardiomyopathy. I agree, it can be confusing because you already have a systemic cause, but then your approach would be when you're approaching a patient for the first time, you don't know whether they have primary form or secondary form. So that is why you have to look for the secondary forms. Okay. Okay. So I hope anyone else with a pressing issue, or if it is okay with you, we may conclude that. Class rep?
Thank you, Dr. Tim, for this amazing class and for answering all the questions in detail.
Okay, okay, thank you. Thank you.
Yes, I kindly request if you can share with me the presentation.
Okay, I will send it to your email, okay?
Email. All right, Doc. Thank you so much, Doc. Have a good day.